Hello, one and all. Today's topic is tricks of immediate resuscitation and counseling. Basically, it deals with the neonatal resuscitation program, which we come across day in and day out in our delivery rooms, both for term and preterm babies. I have told here in this presentation, I will be talking about preterm requirements and the extra requirements for preterm as well. And just keep in mind that basically the NRP protocol and the steps stand same for both preterm and term. Just certain additional requirements are there in case of and extra caution is needed when we are doing preterm NRP. So moving ahead. So why is NRP in preterm important? It's because there is a higher risk of medical complications and additional challenges in them. We need certain additional resources in order to prepare for a preterm birth. And since preterm babies are very prone to hypothermia, therefore we have to keep in mind certain additional strategies to maintain the preterm baby's body temperature. Also, as compared to term, preterm babies are more prone to birth asphyxia as well as respiratory depression because of surfactant deficiencies. So therefore, assist ventilation and oxygen management that we need to know. This we also need to know in case of term babies as well, just that preterm babies are at a little higher risk. Now, we have to know the ways to decrease the chances of lung and brain injury in preterm babies, special precautions to take after the initial stabilization period, and finally, counseling of the parents of extremely preterm babies. So coming to the complications of preterm birth. Now, when we are standing in the delivery room, the first complication to which the preterm babies are extremely prone is hypothermia or temperature instability. Apart from that, because of low lung maturity and weak chest muscles and flexible ribs, as well as surfactant deficiency, these babies are highly prone to respiratory depression or asphyxia. Apart from that, immature tissues are more easily damaged by oxygen, so oxygen injury, and increased susceptibility to sepsis, pneumonia, and meningitis. There is an increased risk of hypovolemia because of blood loss or hemorrhage, and these babies or preterm babies as compared to term babies are at a much higher risk of germinal matrix or intraventricular hemorrhage. And similarly, due to limited metabolic reserves, preterm babies are more prone to hypoglycemia after birth. So now coming to the neonatal resuscitation protocol. Basically, NRP protocol comprises of 4 major steps or 4 modalities. First is the equipment checklist, where we have certain additional requirements for preterm, which I have mentioned in the next slides. Then the initial steps, assessment followed by assessment of heart rate, apnea, and gasping. And this creates the first golden minute of NRP protocol. And here we basically, and this is extremely important to decide the further course. And next comes the 2 life-saving steps, that is PPV or positive pressure ventilation, which can be given mainly by bag and mask or intubation, or if both of these are not possible, then laryngeal mask airway. And then we have chest compression and medications finally. So this is the equipment checklist. This we have, pediatricians have to follow day in and day out whenever we are attending a delivery. So basically, you have to categorize these equipments as per their functions. So firstly, for warmth or of the baby, we need a preheated warmer with warm towels and blankets, temperature sensor. In case of preterm, hat, plastic bag, and thermal mattress. For clear airway, that is mainly for secretions, so bulb syringe and a 10 French or 12 French suction catheter, which is attached to wall suction and a meconium aspirator. In order to auscultate, we need a stethoscope. For mainly ventilation, we need a flow meter, the oxygen flow meter set to 10 liters per minute, oxygen blender set to 21%, positive pressure ventilation device, term and preterm sized masks, and 8 French feeding tube and large syringe. In order to oxygenate, equipment to give free flow oxygen, and pulse oximeter and target oxygen saturation table, which I'll be showing in the next slides. And finally, to intubate, we need laryngoscope with size 0 and size 1 blades. Better to keep size 00 also, because mostly practically while we are doing preterm intubation, 00 for early preterm babies can be required. Apart from that, ET tube starting from 2.5 mm, three types, 2.5, 3 and 3.5 should be present. Then carbon dioxide detector, measuring tape, and also for the ET tube attachment, we need to cut the tape priorly itself, and scissors and laryngeal mask if required. And medications, we do not need much medications. There are mainly two kinds of medications. One is epinephrine, which I'll be discussing, and apart from that, normal saline. And you need certain supplies in order to secure a umbilical vein catheter. So coming to the additional requirements for preterm resuscitation, in order to counter hypothermia, we need a servo-controlled radiant warmer with a temperature sensor, working temperature sensor. For babies less than 32 weeks gestation, we need a polythene bag or wrap and thermal mattress, oxygen blender and oximeter with an appropriate sized sensor, ECG monitor with 3 chest leads, and resuscitation device. Resuscitation device types are many, but the most commonly used both for preterm and term babies is the self-inflating ambu bag. And it is capable, and apart from that, a resuscitation device needs to be capable of providing PEEP and CPAP, because providing PEEP or increasing pressure is a vital step in ventilation correction measures, and such as a TP's resuscitator or a flow inflating bag. So apart from that, after that, we need for ventilation or for intubation and ventilation, we will require a preterm sized resuscitation mask, size, as I said, 0 and 00 laryngoscope blade for preterm resuscitation, ET tubes 3 and 2.5 mm, and surfactant less than 30 if the baby is less than 30 weeks gestation, which is prophylactic surfactant therapy. And then in order to transport the baby from delivery room to NICU, we need a pre-warmed transport incubator along with blended oxygen as well as a pulse oximeter. So as per the AAP NRP 7th edition, this is a table which, depending on the weight of the baby and the gestational age in weeks, it helps us in deciding which ET tube is most suitable. So now coming to the initial steps. Initial assessment has the 3 vital questions, that is the baby term or preterm? What is the tone of the baby? Is the baby limp? And is the baby vigorous or non-vigorous? So once we have answered these questions, next step is giving warmth and positioning the airway. Now they have cut the cord and the baby has been handed over to you, the pediatrician. You have to get the baby to the preheated warmer, which we have already kept ready. And first step is to remove all the wet linen in which the baby is wrapped and place the baby in the dry warmed linen in the radiant warmer and position the airway. The baby's position has to be in the sniffing position. If there is hyperflexion of the neck or hyperextension of the neck, the airway will be compromised. It is better if you can keep a shoulder roll. Okay, and after that, once positioning is done, you have to, if at all there are any secretions, you have to first do a gentle suction, first of the mouth, then of the nose. It has to be gentle suction, because if you're vigorously suctioning, sometimes it can cause vagal reflexes and therefore bradycardia. And after suctioning, you have to dry the baby starting from the head, because the head comprises the maximum surface area. So first dry the head thoroughly and then the trunk and the limbs. Okay, so that is how you dry and stimulate. So these are the initial steps. You assess the baby, warmth and position of the airway, suction if necessary, and then dry and stimulate. These initial steps have to be completed in the first 30 seconds after birth. So since we know that preterm babies are very prone to hypothermia, how do we keep the baby warm? Firstly, the pediatrician has to reach the delivery room well before time and increase the temperature in the room where we are going to receive the baby. Ideally, set the room temperature to approximately 23 to 25 degrees Celsius. Put off the air conditioning. Preheat the radiant warmer well before the time of birth and place a hat on the baby's head. For babies who are born at less than 32 weeks gestation, they say that you do not need to vigorously dry and stimulate. Rather, you have to place a thermal mattress under the blanket of the radiant warmer and wrap the baby in a polythene plastic bag or wrap. This step we do not need in term babies. In case of preterm, you have to wrap the baby in this polythene plastic bag for warmth. Keep the newborn fully covered and monitor for overheating. And the transport incubator also needs to be ready, that is pre-warmed, and try to maintain the baby's axillary temperature between 36.5 and 37.5 degrees. So this is the picture of the thermal mattress. We have to place the thermal mattress beneath a blanket. It should not come in direct contact with the baby's skin, as it is very delicate and thin skin and it can easily get burnt or overheated. You place a hat on the preterm baby's head and cover the baby in plastic wrap. These are two types of plastic wrap covers that can be used. And once we have covered the baby, cover the baby at all times during the resuscitation and the both auscultation as well as chest compressions, if required, can be given from above this wrap itself. So keep the baby covered at all times. Next important step is in terms of ventilation. So positive pressure ventilation. So here I have basically shown the preterm ambu bag. There is also term ambu bag, which is shown in this one. So this is the preterm ambu bag. It's a self-inflating bag, not a flow-inflating bag. And these are both the types of masks. This is the preterm mask and this is the term mask. Now, and this picture shows the correct placement of the mask. So when we are placing the mask, at all times, for the correct placement of the mask, these tips have to be remembered. At all times, the nose and the mouth have to be covered with the mask. The lower margin of the mask should not cross the chin, and the upper margin has to rest on the bridge of the nose. Okay? It is in this way that a complete 100% seal can be formed. Otherwise, if it goes beyond the chin, the seal will be compromised. And the seal is extremely important for effective PPV to occur. This is the way we are supposed to fix the mask and hold the mask while giving PPV. So this is the C and E technique of the fingers. The C formed by these two fingers is in order to hold and fix the mask, and the E formed by these three fingers is going to give the jaw thrust so that the airway is always clear. Now, assist ventilation. Basically, once we complete the initial steps in the first 30 seconds, the next 30 seconds of the golden minute are required to assess for if the baby is having apnea or gasping and if the heart rate is below 100. If it is so, then we have to start with positive pressure ventilation. But if the baby is breathing spontaneously, then we can give a trial of CPAP to the baby. But if the answer to any of these two questions, that is heart rate and apnea gasping, is yes, then we need PPV. And if we are giving PPV, we have to use the lowest inflation pressure necessary to achieve and maintain a heart rate more than 100, because if we are too vigorous with the bagging, it is going to cause pneumothorax or air leak syndromes. And if PPV is required, use a device that can provide PEEP. In case of a baby who is less than 30 weeks of gestation, be ready with your prophylactic surfactant therapy. So for oxygen supplementation, this point is a difference in term and preterm babies. In case of preterm babies, we initiate resuscitation of preterm newborns less than 35 weeks gestational age with 21% to 30% oxygen, and that we maintain by using an oxygen blender. But in case of term babies, we have to start bag and mask or PPV at room air, that is 21%. No need of starting oxygen blender right away over there. So this is the difference. In case of preterm babies, you start with 21 to 30% of oxygen. In term babies, it is at 21% or room air. Use a pulse once we are starting positive pressure ventilation. At the same time, we have to attach a working SpO2 monitor to the baby, and also consider connecting ECG leads to the baby. So and when we are using the ambu bag, breaths should be given at a rate of 40 to 60 breaths per minute. For this, we use the rhythm: breathe 2 3, breathe 2 3, breathe 2 3. The meaning is that when we are saying the word breathe, breathe, at that time we have to squeeze the ambu. And yes, in case of pediatrics, the ambu bag has to be held between these two fingers and the thumb. And the squeezing is also to be done with these three fingers itself. This is going to cause air leak syndromes or too vigorous PPV. So breathe, and during 2-3, we are going to release the ambu bag. And this is the oxygen saturation target range that we are supposed to have at all times while we are going for resuscitation of a baby or delivering a baby. So the two key points are that effective PPV is when you are seeing that there is a bilateral symmetrical chest rise or chest movement. Now, why is bilateral symmetrical important here? Because if only one side of the chest is rising, then you have to consider in terms of pneumothorax as well. So it has to be bilateral symmetrical chest rise. And most sensitive indicator to successful outcome of PPV is increase in heart rate. Now, we have started with positive pressure ventilation, but if we are seeing that there is no chest movement, then we have to go with the ventilation corrective steps, or MR-SOPA. And this acronym stands for mask adjustment, that is to reapply the mask and consider the two-hand technique, then reposition airway, place head neutrally or slightly extended, and after that again try PPV, suction mouth and nose, open the mouth and then place the mask with the jaw a little and lift the jaw forward and try PPV again. Pressure increase the pressure in 5 to 10 centimeter increments and try PPV and reassess chest movement. If still after MR SOAP also it's not happening, then you finally have to intubate the baby or go for an alternate airway. So advanced or alternate airway is basically intubation with ET tubes, and if you see that a baby requires chest compressions, even then you have to leave everything and intubate the baby. And if intubation is not successful or feasible, then LMA can be used. This is the table for ET insertion lengths. So this is an important table. This tells us about the heart rate, first and second heart rate assessments. First heart rate assessment has to be done after 15 seconds of starting PPV. So if we see that the heart rate is increasing with the PPV, you can continue the PPV, and second heart rate assessment can be done after 15 seconds. But if the heart rate is not increasing, but you're seeing that the chest is moving properly, in that case, you continue PPV that moves the chest and again see the second heart rate after 15 seconds of PPV that is moving the chest. What we are mainly concerned about is when you're giving PPV and neither the heart rate is increasing nor the chest is moving. If you are in such a situation, then you have to do the ventilation correction steps. Okay. If the heart rate is also not increasing, the chest is also not moving, you have to do the ventilation correction steps of MR-SOPA. And then the second heart rate assessment is done after 30 seconds of PPV that is moving the chest. So in that case, in that second assessment, if the heart rate is at least 100 beats per minute, you can continue PPV in the same manner until there is spontaneous effort. If it is between 60 to 99 beats per minute, you have to reassess ventilation again and do the ventilation corrective steps of MR-SOPA if necessary. But if the heart rate is still less than 60 beats per minute, this means that we have to go for chest compressions. So intubate the baby and start chest compressions. So chest compressions are started when the heart rate is less than 60 per minute despite adequate ventilation with 100% oxygen for 30 seconds. It's delivered at the lower third of sternum to depth 1/3 of the AP diameter of chest, and two techniques are used, that is two thumb encircling hands technique, where your hands are like this, and it's actually shown in the picture as well. And otherwise, compression with two fingers can be done with the second hand supporting the back. But two thumb encircling technique is much more preferred and commonly used. The chest compressions are given at a ratio of 3:1, and that is 3 chest compressions is to 1 ventilation. And continue the chest compressions for 60 seconds before rechecking the heart rate. So this is how you're going to give. One important thing is that it is even shown in this picture. This is the placement of the thumb on the anterior 1/3 of sternum is very important. The thumb's flat surface will lead to pressure being divided. So it has to land like this. This surface has to land on the skin, and this is what is giving the pressure. If you are using this, then the pressure will be submitted and adequate pressure to the chest compression will not be there. Right. So next is medications. Basically, it is epinephrine and volume expander. Epinephrine, the solution that we need to prepare is 1:10,000 epinephrine, 0.1 mg per ml. The preferred route is IV, and the dosage is 0.1 to 0.3 ml per kg. And it has to be administered as quickly as possible when you're giving. Whereas volume expanders, that is if you're suspecting that the baby has had a hemorrhage or hypovolemia and the heart rate is not increasing in spite of giving 1 dose epinephrine, you have to consider volume expanders. So that is normal saline. You give IV through the UVC, and usually at 30 to 60 ml syringe over 5 to 10 minutes. So in order to prevent any resuscitation associated injury or intraventricular hemorrhage during resuscitation, handle the baby gently and do not position the baby's legs higher than the head. Avoid delivering excessive pressure during PPV or CPAP, and use a pulse oximeter and blood gases to monitor and adjust ventilation and oxygen concentration. Do not rapidly infuse IVF because this rapid infusion can also cause intraventricular hemorrhage. So this is basically our NRP protocol. So what do we do? First, after birth, we have received the baby. We carry out the initial steps that I have already explained in the first 30 seconds. After the first 30 seconds and after the initial steps are done, the next 30 seconds are to be utilized in order to assess for apnea or gasping, or if the heart rate is below 100 beats per minute. This makes the first golden minute of NRP protocol. If there is apnea or if the heart rate is less than below 100 or less than or below 100, in that case, attach a SpO2 monitor to the baby. Consider attaching an ECG monitor because we have to start positive pressure ventilation now. After giving first PPV for 15 seconds, you are going to check the heart rate for the first time. Now, in the first assessment, if the heart rate is below 100, then check chest movement and do the ventilation corrective steps of MR SOPA. And after 30 seconds of PPV, that is moving the chest, you do the second heart rate assessment. And if the heart rate is still below 60, intubate the child if the child is not yet intubated, and plan for chest compressions. And for that, coordinate with PPV, and now you have to give 100% oxygen to the baby. Working SpO2 monitor and working ECG monitor has to be stay connected to the baby. So after 60 seconds of giving chest compressions with proper ventilation, you are going to check the heart rate again. And if still the heart rate is below 60, in that case, the first dose of IV epinephrine has to be given. And if heart rate is persistently below 60 BPM, consider hypovolemia or consider a pneumothorax if the chest movement is not equal and symmetrical. And accordingly, you have to give volume expanders as well. So these are the ventilation corrective steps of MR SOPA. And this is how each step by step you have to do the NRP. So now coming to counseling. So in case of counseling, we have to meet the parents before going to the delivery room, discuss the goals, and share all the risk factors and information with the parents. In case of high risk deliveries, establish, and especially in case of preterm where there are many risks and complications involved, establish a trusting relationship, but do not be too negative, and also do not be too overzealous about anything. Do not promise anything to them. Tell them that you are confident and you are a good team and you're going to give your best, but there are multiple complications and therefore do not promise anything. Ideally, both the obstetric and neonatal caregiver have to be present. Use clear language without any medical abbreviations or jargon. If you have visual aids and written materials which can help to explain better, use those. Very importantly is documentation. Once you have explained everything to the parents, it is better that you document everything, and also if possible take signature from the parents. And in case of do not resuscitate, both obstetric and neonatal personnel should be informed and both should be on the same page about it. So specific counseling, basically this is in relation to high risk and preterm deliveries mainly. So in case of preterm deliveries, we have to convey certain specific counseling points. That is, this we have to explain the parents that this is going to be a high risk delivery, and unlike term babies who are born with good weight and who are shifted immediately to mother's side, this baby is going to be a little weaker and is going to be is extremely delicate due to preterm, and will have lower birth weight, so might not be able to feed like the stronger term babies. Also, there is a risk of a much higher risk of birth asphyxia in these babies, as the organs have not completely matured as compared to term babies. Therefore, there is a chance of brain hemorrhage as well as a chance of surfactant deficiency, and therefore the baby might need CPAP and mechanical ventilation as well further. Owing to all these complications and factors, it will be a prolonged NICU stay for the baby. Um, and we also need to warn them about the during NICU complications, like the baby is prone to develop respiratory distress syndrome, very prone to have multiple infections or complicated infections or sepsis, hypothermia and hypoglycemia, and NEC. Uh, Early preterm are related to having certain complications even in the continuing in the a further life, that is ROP, developmental delay, and BPD. And apart from explaining them about these various complications, since it is related to prolonged NICU stay, you have to inform them about the financial burden. Be very practical about everything, and explain them that this is an important step. These things are absolutely necessary, but at the same time, it is going to create a financial load on you. It will be a it is going to be an expensive matter, but we are going to try our best. But it is better that you be aware of all the pros and all the cons related to a high risk delivery like this. So this is all in a nutshell about NRP and counseling. So that is so we have to be very thorough and very clear about the NRP protocol, because it's an extremely important and extremely important aspect of pediatrics, and also bread and butter. So thank you very much.